Okay.
Okay. So, dear friends, let me welcome you on behalf of Dr. Dhiren Ganjwala's Pediatric Active Orthopedic Learning Tutorials. And we are fortunate that we have a really great guy today with us. This is the only surgeon whom I know who is so humble and yet so knowledgeable. I've had the fortune of knowing Sanjeev Madan from Sheffield, UK, over the last 5 to 7 years. And he's from Mumbai originally, JJ Hospital, and has been as a consultant in Sheffield for a long time. And he's the only person who operates on the hip from the womb to the tomb. So he is doing pediatric, adolescent, arthroscopy, hip reconstruction, hip replacement, revision hips. You name it, and he does it. So we are fortunate that he is here with us today to talk to us about slipped capital femoral epiphysis, his thought processes in management, diagnosis, and how we should approach it. Welcome, Sanjeev, on behalf of the forum. Thank you very much for sparing your time.
Thank you very much, Sandeep, for such illustrious introduction. So, slip upper femoral epiphysis is a term which is a misnomer, and what it is that the upper femoral epiphysis stays in the acetabulum, and it's the metaphysis and the shaft of the femur that rotates around. And what happens is the displacement is such that if you say slip upper femoral epiphysis, the slip is typically documented in the books is that it slips inferiorly, posteriorly. Okay, but what actually happens is creates a deformity, a displacement, and that is actually of the metaphysis and the leg. What it does is it creates an external rotation deformity in chronic slips. It creates a reduction of abduction, actually reduction of abduction, and in severe cases adduction deformity it can create if you get chondrolysis, and also extension, loss of flexion. It creates loss of flexion. So you can understand. So let's start with this then. Let's go to the first slide. So displacement of the capital femoral epiphysis from the femoral neck is through the physeal plate. Physeal plate is the growth plate. 15% present with isolated thigh or knee pain. Any kid, adolescent from 8 years typically who presents with knee pain, always screen the hip, get the patient prone, and then do internal external rotation. And if there is a difference, you should suspect between 8 to 15-year-olds a slipped upper femoral epiphysis. Incidence is 10.8 per 100,000. This is a typical Western population incidence, but I think in India it may be the same now. Male to female ratio is 1.5 to 1. Bilateral cases is in 20% of cases, it is bilateral. 20% of them present as bilateral, and this is 20% bilateral is symptomatic bilateral. If you consider asymptomatic, there is 61 to 70% can be asymptomatic, have slip on the other side. These are some studies done. So this is a typical sign on X-ray. You will see the slip. If you see an AP X-ray, you see this is a normal side, this Klein's line. If you on the superior part of the neck, if you draw a line, it cuts the head, and this is normal. That's what you should see. Whereas in slip, it will not cut the head because the epiphysis has slipped inferiorly. On the Southwick angle view, if you see on a frog lateral view or Longstein view, you'll see the difference in the angles. The normal angle here is the head shaft angle, which is normally is 12 degrees. Here it increases to 49 degrees. So 12 degrees or 13 degrees is considered as normal. Next one, next. So there are classification of slip, time-based classification, the stability, unstable or stable, loader-based classification, severity of the slip, okay, mild, moderate, severe, and unstable. In unstable slip, there is 50% chance of AVN. Time-based is acute on chronic, and chronic slip. Yeah, and stability is, and unstable is that the patient cannot bear weight at all. He will suddenly have pain in his groin, or he fall, and after that he cannot put weight on it, and that is unstable. I like this classification as stable and unstable. And then the second bit is of severity of slip. So the slip angle is difficult to say on an X-ray and AP, because if it is acute, you can't get a frog lateral view. That will and if it is a chronic slip, the position of the leg is not very accurate to get a angle of the slip. So we devised a classification to know the exact magnitude and direction of the slip, because that helps not only to plan the trajectory of the screw, if you have to do pinning in situ, trajectory of the screw, if you have to do pinning in situ. But sometimes it is so bad, it's so severely slipped that pinning in situ is a very unstable position biomechanically, and we may have to have other strategies like opening the hip to reposition the epiphysis back into anatomical position. Next slide. Next one. Yeah. So this is a classification which we put forward in 2014, is a oblique plane classification where you get some axial slices of the hip, and you get this angle on an axial plane, and then you do a next slide, and then you do an X-ray, and on an X-ray you see the slip. So we combine these two, you do a pythogram. X is, so this is the y degree of displacement of the epiphysis, and the x degree of displacement is seen on an X-ray. Next slide. Yeah, keep going. So but then you combine see, this is the X-ray, x degree of displacement, and this is the y degree of displacement, and then you plot this. Then you get the direction of the slip, and you get the magnitude of the slip. So remember, z is the magnitude of the slip, which is always more than the x and the y together. And this is the oblique plane way of understanding the slip, and actually also showing the direction of the slip. Next slide. I mean, this is a three-dimensional way. If you see in the CT, you will actually see the true magnitude of the slip. X-ray always underestimates the slip angle. Next slide. So we used this type of classification, and we asked even the registrars and the fellows to, compute the angles and the magnitude, and it was pretty accurate. Coronal plane, transverse plane, true deformity. The interclass coefficient showed that the agreement between an experienced surgeon and even a junior fellow, it was reasonable. So it is very easy for someone who is in A&E or first time he sees the patient and he does a CT scan and an X-ray, he can actually compute and say that, oh, this is severe. So these are secondary factors. So these are secondary factors. You can see obesity, renal failure, growth hormone problems, hypothyroidism. These hormones, they increase the width of the growth plate. So that becomes a weaker area, hypertrophic zone. And these adolescents, they run around, they twist, and they cause shear force. And that's how the slip happens. Okay, so next, but most often than not, actually, these kids are normal. Either they're very tall or for their age, or they are obese. But sometimes they're quite normal as well. Majority will be 80% will be quite normal kids. So the factors, pathogenesis factors are that there is normal periosteal thinning that happens and widening of the physis, which occurs during physiological hormonal changes at adolescent period. So they play football and do trauma or run around, and that causes slip. Obesity increases the mechanical strain on the physis. The inflammatory changes are secondary, I think. They're not the primary changes. But it's been proposed that inflammatory changes primarily can cause as well, and it is known. But in an idiopathic kind of slip, it is secondary. Genetic predisposition, as I said, genetic disorders, Downs and other syndromes. And we touched on endocrine problems. There are certain pediatric cancer group patients it can happen. So contralateral slip, there have been several papers on this. When to pin the contralateral slip, or what is the risk? So I think in general terms, if you see on an X-ray the triadiate cartilage is open, then you do pin the other side as well prophylactically. That's a very simple thing to do. These papers, there are many papers. These papers basically say posterior sloping angle. I will go on the next slide to explain that. But basically, I would say that you read this paper for the fellows. These are some things that you have to read, and so y'all can then compute, you see. But a general thing, Oxford bone age is, again, they are very young for their age. Skeletally they are young. So if they're skeletally young, that means the bone age score is 16, 17, or 18. Then again, there is a high chance that the contralateral side may slip. So you pin prophylactically. Next slide. So, I mean, if you see the posterior sloping angle is measured like this, you draw a shaft line and then you perpendicular line to that, and then the edges of the epiphysis, you draw a line, and you see that posterior sloping angle is 12 degrees normally, but if it increases this, then it is more. This is a little bit more. So then 10-year-old
Again, I think we lost him.
Yeah, sound is gone.
Sanjay, we are not able to hear you.
So sorry to interrupt, but the streaming and recording has been stopped.
No, don't worry. Don't
It's
worry
okay.
about that. We are just continuing with the session if possible. Don't worry, Poonam, about that.
So hello.
Yeah,
Can
please.
you hear me? Yeah. Okay. So next slide then. What I'm more saying is that, see, on the left side the score is high because skeletally immature, and the triradiate cartilage is open. To go this scoring, you need to read the paper, fellows, and then you will understand how to score. Basically, when triradiate cartilage is open, acetabulum, if the child is immature, the safe thing is to pin the other side. That's the bottom line. Okay, next slide. So in situ pinning, single cannulated 16 millimeter threaded screw is a general standard. You can use 32 millimeter, doesn't matter. Center to center, a position of the epiphysis, center to center. That is important. 5 millimeter from the subchondral bone. Your screw should be 5 millimeter from subchondral bone. And you have to check it, actually, a dynamic checking of moving the hip in all directions to say that you're not penetrated the joint. And fewer than 5 screw threads demonstrated progression. That means if you have less than 5 screw threads, it is a chance that the screw will not hold the epiphysis, and there can be progression. Even with the screw in, the epiphysis can continue to slip. You could do arthrogram, but it's not very necessary. And computer navigation is a research tool, actually. Okay, next. So this is a typical positioning of the patient fracture table, so that you can do both lateral and AP X-rays. It is advisable that before you scrub, actually do an AP and a lateral X-ray with a C-arm to show that, see that you can see everything properly, and then go and scrub. This is very important. And next slide. So pinning, generally speaking, see, the slip is posterior and inferior. So your entry point usually comes out to be on the anterior part of the metaphysis or anterior part of the neck of the femur, and it has to be projected posteriorly. You can see, and what you do is you do on this right side C diagram, it shows that you put a guide pin on the skin above and do an X-ray to see where the pin is in the center of the head, and you mark that with one line. And then on a lateral X-ray, you put it again like this, you can see, and mark that line on the skin. So the intersection of these two lines is the skin incision, so that you have a smaller skin incision. And then you put the threaded pin in on the neck, and again check on AP and lateral, and then drive your pin to the epiphysis. Next slide. So pinning in situ, I'll come to this. Pinning in situ is the standard practice. Remember, to be safe in your practices, if it is always pinning in situ is the safest thing to do. Okay, so there are different screws available in the market, but they're fancy, really. This allows growth of the epiphysis, that you can have the screw in, but prevent it from slipping, but allow the growth. Now, can be used for very young children. We went through a phase, actually, I don't like this, my colleagues did it, and they created such secondary deformities in the femoral head and neck. But that is very, we could discuss this later. But but these are the things available in the market. Next slide. Yeah, this is just an example to show the growing screw. Next slide, telescoping screw. So, I mean, we had done a short study, and what happens is that it's growing. The screw, you can see from the right, the X-ray from the left side going to the right side. The screw was inserted, the growth happened. This is a growing screw. So then again, the screw was changed to put another screw. This creates actually a secondary deformity of retroflexion. These growing screws, so I don't like them. Okay, next slide. So slip progression appears inversely related to the number of screw threads engaging the epiphysis. That's what I said, that you have to have enough threads to hold the epiphysis steady. So to advance the screws until you get 5 threads engaged across the epiphysis. And this is the paper that had quoted that. Next slide. I mean, I think this is not, yeah, this is working good. So you can use a software to see in chronic slips and see where the impingement is happening. And you click on the other side, the other one, and you can you will be able to sometimes see that these bumps in mild slips or moderate slips where they're impinging. You can use a software, and then you can plan treatment. You can pin this now and then later on do arthroscopy and things like that. So clinical graphics is one which I've used sometimes. Next slide. So Manoj Padman was, when he was a fellow with us, we had just presented in 2010 BJJ paper. One is the slip, even a mild slip sometimes can cause significant deformity and problems. And that is due to, if your hip is profunda hip or protrusia profunda hip, that causes a compounding effect of not only a cam problem of femoroacetabular impingement, but also a pincer problem. And that causes severe acetabular retroversion over femoral retroversion. And this type of is a lethal combination. So combination of pincer and cam, and you have to be aware of this before you treat this, because you will have to do some other strategies to improve the function of the patients. Next slide. So clinical findings in skiffy with FAIs obligate hip external rotation and abduction with hip flexion, prominent screw head. So this, after screw pinning, if there is moderate to severe slip, you can get screw that is impinging. The screw head is impinging on the acetabular rim. The cartilage damage happens, is always observed on the anterior and superior quadrant when the slip is inferior and posterior. Metaphyseal prominence impinges on the cartilage during flexion. In every surgical dislocation I've seen, even in acute cases, there's always chondral damage. Next slide. So traditionally, for chronic slips, for correction of FAI, the secondary changes were done, secondary osteotomies were done, like Southwick, Mauser, and Dunn, where they kept the relationship of the head and neck same, but did an osteotomy at the intertrochanteric level, so that, you know, you could kind of get the bump away and not articulate and get into the acetabulum to cause this problem. But there is limitation of that. That's not anatomical correction, and you create another deformity. So it's more popular nowadays is arthroscopic femoral head neck osteochondroplasty. You could do it with an open surgery osteochondroplasty or with surgical dislocation. And you can do a combination of procedure of Mausers and also a head neck osteoplasty. Next slide. These are for chronic slips generally. So we had actually presented published a paper in 2016 about the patients who were treated with pinning in situ and then who developed symptomatic FAI, femoroacetabular impingement. And then we did an osteoplasty on those patients and showed that actually after the slip, if they take a long time to get symptomatic, then after the arthroscopy of removing the bump, the outcome is not as good as when they got symptomatic in the first year or two. Then the outcome is good. So it shows that actually more cartilage damage, then the outcome of even arthroscopy is not good, because the progression of kind of chondral damage is a bit too much. Okay, next slide. So I don't know whether this will work. Okay.
Yeah, it's working.
Okay, so these are the portals. If you see, this is lateral part of the hip, And you can see that the mark is there. It's superior and anterior to the tip of the trochanter is your first entry portal of viewing portal. And the second portal is actually anterolateral on the line that is, so the line in the anterior part of the hip is from the ASIS. It is drawn vertically down. So this line where the second portal is the midline between the first line from the ASIS downwards and the shaft line on the lateral side. So this line, middle line, and that's the second portal, and it subtends a 45-degree angle. This portal allows both central and peripheral compartment to access, so that you can treat, you can look at the chondral damage, you can do the other things what you want to do. Next slide. So you can see this, you do the impingement test. The femoral head is moving in the acetabulum. So before and after your osteoplasty, you should check and move the head to see that you corrected the impingement. Next, click next. Yeah, so this shows the osteochondroplasty at the femoral head neck junction. Okay, next slide.